Hi everybody. So today I wanted to talk about a question that gets asked a lot by new clinicians, but also from clients. QEEG, mini-map, arousal model assessment, what's best? So I want to start by saying that something that Dr. Ed Hamlin has said to most of his classes when he teaches beginners and probably even advanced people, that everything we do in neurofeedback works, but it doesn't work for every person. Our field is poorly funded, so our research tries to do the best that it can to determine who's going to be best helped by what. But we're still in our infancy in terms of knowing who needs what and what protocols, what approaches help best with whom. I promise that's something researchers are actively working on, but it is going to take time. So in the meantime, as clinicians, as people who are suffering, who want relief, we try to do the best we can to figure that out. But it's important to remember that no neurofeedback approach in and of itself will be a miracle cure. It won't be for me, it won't be for you. It takes layers, peeling back layers of problems and issues and trying to help them one at a time with the best approach we have at that time. That can be neurofeedback, that's counseling, that's healing life circumstances, healing through how you treat your body, what you eat. All of the above comes into how we're doing today and will affect all the different pieces. Neurofeedback can be one of those pieces, but none of it will ever be a miracle cure. It all works in conjunction with the other things that we're doing. So when you put all of that together, that's kind of the caveat. We still have to figure out which one is going to work for whom. The first thing is that the arousal model and the arousal model assessment should basically underlie, in my opinion, and somebody can yell at me about it, all neurofeedback. That's why I'm a firm believer in having clinicians and clinical people involved in even the really technical QEEG stuff. Because what is most important about neurofeedback is the effect it has on you. Because at its core, neurofeedback isn't doing something to you. We are inviting the brain, based on the feedback that we give it, to make changes. But every brain gets to choose exactly how it makes those changes. So if it makes those changes and it feels bad to you, then it is not good. And your clinician should be paying attention to that, listening to it, and trying to figure out how do we deal with that. And the arousal model is how we know where did you start, what are your symptoms, over-aroused, under-aroused, unstable, which take out the connotation, just means ups and downs, and then disorganized, which has to do with significant trauma. So we should know where you start, and then we should know how things can affect that and how your symptomology falls into that. So the arousal model is not separate, but there are lots of clinicians like Seaburn, my mentor. That's all she needs. She is so brilliant at her arousal model assessment that that's all she needs to determine protocols. And that works for some people, and other people need data. I learned to do mini maps, especially when I'm feeling stuck. I find that they're really super helpful to kind of take a fresh look at things. It's kind of like a rewind, but it's also, taking a short reading at a moment in time and figuring out what doesn't look right. And we have some norms, but always be careful with norms. Not every brain's the same, and not all of us want to look like or be like or act like other people. We're not robots. So we always have to be careful about, quote, norming people. But there are general accepted ways that if you have really fast brain waves off the charts in your right side temporal lobe, that's not generally going to feel good. This is also where the arousal model comes in. If we ask the brain to change and that feels better, we're not norming, we're creating a positive effect. So the mini map is a really great middle ground also because it's cost effective. I can do it right in my office with the sensors and equipment that I already have. For me, it's just 3 spots on the head and 7 minutes of recording. So in that way, it's great for people who don't have the probably, depending on where you are, $600 to $1,500 to do a QEEG and analysis. So that brings me to the Q. The Q is either 19 or 32 channels, that's how many sensors are on the head, map for 10 minutes with your eyes open and 10 minutes with your eyes closed. Eyes open is your interaction with the world and how that impacts your brain. Eyes closed is your internal world. And that gives us an understanding of what's happening in both places. Cues are really important when somebody has head trauma, seizures, things like that, because you want to know what you're kind of dealing with and if there's anything medical that could be treated. But even then, there's some really great work by Dr. Rob Coben about multivariate coherence training that I really think captures something different than amplitude training. It's been my experience. We use his work a lot in my practice, so it's been other clinicians' experience. It's not perfect either. There are people who do it and nothing happens. But it's trying to capture a different element of the very complex brain. So the thing to know about QEEGs is it actually matters more who analyzes your QEEG and gives you the protocols than the actual anything else about it. As long as you get clean data, who analyzes it, if you go to 5 people for your QEEG review, you will get 5 different treatment approaches. So finding someone who's doing your reviews that really matches with your clinical style is really important. That's why I work with Dr. Rob Coben, because he's done a lot of research on developmental trauma, which is my primary population. He has also worked with children, adolescents, and adults, so that works since I have mostly 12 to 25-year-old patients. So he matches with what I'm doing, but you may find someone else who matches better with what you're doing. If you have primarily just ADHD learning disabilities, you want someone who really understands that, and then keep following the patient, the client. What are they reporting? Are they things getting better? And if they're not, that doesn't mean you messed up or the reader messed up. It just means that this is a living, breathing process, and you have to move with it. You can't just assume, well, the number said this, so then this didn't happen, so now it's all... It's not. It's just that every human responds differently, and we have to adapt with them. No one's right or wrong. We're all just trying to figure out this puzzle together, and the brain is infinitely complex. So that's my spiel on, with lots of hands, on QEEG. I hope that's helpful. If you agree with me, disagree with me, comment, send me a message. I love to engage in conversation with this. There are people, I'm only beginning my understanding of QEEG. One day I will probably be doing the analysis, but I'm not there yet. So there are probably people who know a ton more than me, and I'd love to hear your thoughts. So post, comment, and talk to you soon.